Early assessment and management of trauma. ATLS, it is an advanced trauma life support. ATLS is the training program for medical providers in management of acute trauma cases developed by the American College of Surgeons. It is a goal that teaches a simplified and standardized approach to trauma patients. In history, this was made when James K. Steiner, an orthopedic surgeon, met with an air accident while piloting his flight. These are the common steps of ATLS program. First is preparation, second triage, primary survey, which is an ABCDE approach, resuscitation, adjacent to primary survey and resuscitation, secondary survey, adjacent to secondary survey, continuous post-resuscitation monitoring and re-evaluation, and finally definitive care. Preparation phase is based upon pre-hospital phase and hospital phase. Pre-hospital phase is a coordination where the pre-hospital agency and personnel can greatly fasten the treatment in the field. They inform the receiving hospital, which mobilizes the trauma team to ED. Whereas in hospital phase, this is advanced planning for the trauma patients, beneficial. It saves time. Then triage. Triage is a term derived from a French verb trier, meaning to sort or to choose. It is the process by which patients are classified according to the type and urgency of their conditions to get the right patient to the right place at the right time with the right care provider. Now, triage is classified on the basis of color. So, whenever you are in an area where a huge trauma has caused, you will assign patient in terms of treatment by color. It can be either red, yellow, green, or black. Red is for immediate. Those are such patients who have received chest wounds, are in shock or open fractures, or second or third degree burn. Yellow is for those patients whose treatment can be delayed for a few 30 minutes or to an hour. These are stable. These patients have stable abdominal wounds, or there could be an eye injury or CNS injury. In the green one, they do not immediately have to be, they do not need an immediate resuscitation, or their wound is not that great that they would not survive without it. The medical treatment could be given after a couple of hours, or they can be left alone and later on treated. So these include the minor burns, the minor fractures, or the minor bleeding. The fourth, the black one, is the expectant. These are those patients whom are already pronounced dead. Then the second point is the primary survey. The primary survey is composed upon ABCD approach. A is for airway, B is for breathing, C is for circulation, D is for any form of deformity, E is for exposure. That is not written here. So in A, what we do is whenever we find a patient, we need to maintain their airway and check if they are unconscious or not, and consider an advanced airway. In this, we use a chin thrush maneuver, in which the chin is uplifted and which also helps to clear the pathway if the tongue is falling behind, which is restricting the airway. We need to monitor advanced airway if placed when the quantitative waveform capnography. In B, what we do is we establish a proper circulation, proper breathing. We give 100% oxygen and assess the effectiveness of ventilation by performing wave capnography. Be mindful that do not overventilate the patient. In C is for circulation. We evaluate the rhythm and the pulse. If we defibrillate the patient or by cardioversion, and we obtain an IV access and give them the necessary form of medication. In D is for checking any form of deformity or disability. This is, we check the basically cardiac rhythm and patient's history, and other key differential diagnoses are made in this stage. On E is exposure. We expose the body fully. Wherever the damage is, we further process and assess it. ATLS as resuscitation. What we do is we pass an NGT aspiration if not contraindicated, and we do ECG monitoring and correct any form of arrhythmias if present, and the data flow sheet of vital parameters is received. And if the patient is not resuscitated, we can do BSL technique, which is the CPR. Then adjacent to the primary survey and resuscitation, we can also do an ECG. A urinary and gastric catheter has been passed, and similarly, we if any other problems have been caused, we can similarly relieve it. In the secondary survey, this is a lot more important. We do a head-to-toe examination, which is normally done after primary survey in order to check the vital signs and assure the patient is stable. This includes this process is start from the head, then the chest, then the abdomen, pelvis, spine, and extremity. After has been done, we take a history. History key point or a mnemonic for this is AMPLE. AMPLE, A stands for allergies, M for medication, P for any past illness or pregnancies, L for last meal, and E for events and environment relating to injury. After getting these secondary knowledge, we can assess the patient and perform a proper secondary survey. Then we have adjacent to the secondary survey, we can also do a radiology. We can do a fast scan, which is focused abdominal sonography. We can pass the Foley catheter as the patient will be unconscious or not be fully responding, as he or she may be in shock. So, and we need to control pain. If the patient is awake, we need to give tetanus. We need to assess the tetanus status, or antibiotics for open fracture are given. Then we have to re-evaluate the patient. The re-evaluation of patient, we consider a second look. We find new findings if present, and there's continuous monitoring of the vital organs and the urinary output. The urinary output should be more than 0.5 ml per kg per hour. We also do ABGs, ECG, pulse oximetry, and effective analgesics are given. In the definitive care, this is done after the secondary survey, followed by radiographic evaluation. In this, in the definitive care, we put the patient in the right ward. If the patient has a head injury, we take the patient to the neurosurgical ward. If the patient has sustained any fracture, we will admit in orthopedic surgery. And in a vascular problem, a vascular surgeon, a surgeon dealing with such a thing would be informed. And the patient is transferred to ICU, operating room, or any other higher facility if present. The definitive care plan consists upon the following techniques. FAST, which is a focus assessment sonography for trauma. The advantage of this is that this detects concealed hemorrhages, but it does not tell us about the source of the hemorrhage. But it is 100% sensitive. The disadvantage of this process is basically operator dependent, and this device cannot detect the diaphragm, the bowel, pancreatic injury, bowel gas, and subcutaneous air distension. The indication of this is an unstable blunt trauma patient. DBL is a diagnostic peritoneal lavage. The advantage of this is differentiate blood and bowel. This is less time consuming. It is contraindicated in pelvic and fracture and even in pregnancy. The disadvantage of this is this technique is invasive. So hence we cannot practice it on some patients. Massive injury to the diaphragm and retroperitoneal areas. So this can cause injury to diaphragm as well as the retroperitoneal areas. Indication for this is in unblunt trauma and penetrating trauma. Lastly, we have the CT scan, which is the most specific and most commonly used. This is a non-invasive technique, but it misses the diaphragm and the bowel as well as the bowel pancreatitis. In fast examination, we have 4 views. We have Morrison pouch view, we have xiphoid view, which views the heart, and similarly the fast right upper quadrant, the Morrison views, it shows us the views between the liver and the kidney in the right upper quadrant. First place the fluid collection in the supine patient. In the subxiphoid, this evaluates for pericardial fluid. This views through the liver and transhepatic or transsternal and searches for the fluid between the heart and the pericardium. Then the left upper quadrant view is between the spleen and the kidney, and another dependent area for the fluid to collect. It also sees the diaphragm in this view.